We have our next speaker with us, Dr. Angshuman Mukherjee, a renowned pulmonologist practicing in Kolkata. And to chair this particular session, I'd like to invite Dr. G.P. Bhattacharya, one of the founder member of HDS, and Dr. Arindam Dotto, a renowned pulmonologist attached to Narayana Hospital, Howrah. Okay, sorry. Dr. Arindam Dotto is a renowned chest specialist attached to Narayana Hospital, Howrah.
Okay, first of all, I would like to thank the organizers for giving me the opportunity to be here. And at the outset, before this presentation begins, this is vastly a gray area with very limited evidence on this. So I think it is more than apt to have one of the most prominent pulmonologists from Kolkata, Angshuman, who is a very dear senior of mine. I know him for quite some time, and I think he is the best person to deal with the gray areas. And Angshuman doesn't need any introduction. He was a very prominent pulmonologist and young dynamic pulmonologist. He was previously in 40s, now moved to MRI or the Manipal hospital. So over to you.
Thank you, Arindam. Thank you. Good morning, all of you. And I thanks to the Howrah Diabetic Society for giving me this opportunity to speak on this podium about such a gray area of our collaboration. I mean, the endocrinologist and the pulmonologist are collaborate in this scenario, but unfortunately, there is very less amount of evidences which actually shows that the impact of COPD on diabetes and the vice versa, which was told to me to present, is actually happens. So that is the controversy, and I will focus on the pathophysiology, which is one of the common pathway. The commonality of this pathway is so beautiful that you will get to understand about this, that COPD and diabetes, both being a chronic disease, both being an inflammatory disease at some point of time, they are interlinked, intertwined between each other, and that what I will do in next 15 to 20 minutes. So you know better than me that diabetes is a widespread metabolic, hormonal and microvascular abnormalities. It actually causes the disturbances of function of many organs, and the program schedule, it shows that you people are thinking about different organs which are being affected by diabetes, and that is the crux of this disease, that it actually destroy different organs. Equally speaking, COPD at some point of time, it was known as a disease of lungs only. Okay, it is caused by smoking, it is caused by pollution, it is a airway constricting disease, airway obstructing disease. But right now, we have enough evidences that COPD is another disease which, because of virtue of different toxins and different metabolites, if I say so, it actually hampers different organs also. So if you see COPD hampers brain, COPD hampers heart, lung, kidney and everything. So that is what these two diseases are interlinked, and the kidneys, the eyes, cardiovascular system, the respiratory system, all can be damaged by the diabetes, and lung become a target organ for diabetic microangiopathy, as you all know. So the pathogenesis of major long-term complication of diabetes currently thought to involve both the microangiopathic process as well as non-enzymatic glycosylation of tissue proteins, thus rendering the lungs as a target organ. That is the general process which happens in case of diabetic patient who has got COPD. What are the evidences of pulmonary microangiopathy? If I look back to the literature, it shows that thickening of the alveolar capillary as well as the pulmonary arteriolar walls and decreased lung capillary blood volume in patient with type 1 DM is the major consequences which happen in pulmonary microangiopathy because of diabetes, and there is a random pattern of tissue involvement in diabetic patients. So it is either the changes in collagen or the elastin components which significantly affect the behavior, or the other that normal this is what is normal elastic structure. It has got a compliant properties of the lung which require that all connective tissue elements work in a harmony and are in proper spatial orientation with one another. That is the normal. But because of diabetes, there is either the change in collagen or the elastin. This is in general literature that diabetes may increase the risk of COPD exacerbation as well as mortality. I am not going into detail of the statistics, but generally hyperglycemia with a random blood glucose of more than 7 millimole per liter is associated with poor outcome, increased COPD related morbidity and mortality in hospitalized patient as well as in intensive care unit, and I will be talking in detail about that. Hyperglycemia upon presentation to the intensive care unit was found to be an useful predictor, very useful predictor of poor outcome and to confer the greatest risk of treatment failure with non-invasive ventilation patient with severe COPD. আমাদের কাছে যখন সিভিয়ার সিওপিডি পেশেন্ট আসে জেনারেলি যদি প্রথমেই পেশেন্টের সুগার থাকে আমরা বলি যে দেখুন সুগার আছে একটা বড় প্রবলেম পেশেন্টের কিন্তু ভালো হওয়ার চান্স কম বা হলেও দেরিতে হবে দ্যাট ইজ আওয়ার জেনারেল ডিকটাম What is the epidemiological evidences linking to COPD and type 1 diabetes? I will be talking both about type 1 as well as type 2 diabetes. The prevalence of type 1 diabetes was previously reported to be increasing over the past decade. What happens in type 1 diabetes? There is reduced total lung capacity, reduced DLCO, that is diffuse capacity of the lung for carbon monoxide. The pulmonary elastic recoil, as I told you, it reduces, and the end expiratory lung volume reduces, which has been detected in patient in different studies. It has been detected in patient with type 1 diabetes. This impaired lung physiology inversely correlated with glycated hemoglobin levels. And the changes in collagen glycation of lung parenchyma and alveolar microangiopathy may contribute to this altered pulmonary dysfunction. And in a small comparative study, it was shown that type 1 diabetes patient exhibited normal spirometry and pleural pressure, but higher dynamic elastance during hypoxia, possibly indicating peripheral airway involvement. Now, what is happening in type 2 diabetes? Hyperglycemia, it is generally considered as an independent predictor of poor outcome, as I was telling you. If there is baseline hyperglycemia as per the Apache 2 score, it shows that it is a good predictor of clinical outcome determined by this Apache 2 score, and mortality rate is quite high in patient with COPD and type 2 diabetes. Death is almost 80% of patient within 9 years of hospital admission because of acute exacerbation of COPD, and diabetes mellitus was associated with decreased long-term survival in this patient. Diabetes as well as cardiovascular diseases, it increases mortality. You all know about the syndrome X or the metabolic syndrome, and diabetes and cardiovascular disease, they actually increases the mortality in a cohort of COPD patient when it has been adjusted for age, gender as well as smoking pack year history. So, type 1 diabetes, it affects specific lung function, as I was telling about TLC, about DLCO, also it reduces the FEV1. So, there are lots of data which shows that this lung function actually got decreased even in patient with non-smoker who are having COPD as well as having type 1 diabetes. Patient with higher HbA1c level have lower FVC, FEV1, vital capacity and peak expiratory flow. These abnormalities can be mitigated. This is important. These abnormalities can be mitigated in just 3 months after correction of hyperglycemia. Lots of write-up, that is systemic inflammation, significant role in pathogenesis and progression of COPD and diabetes. I will talk about this inflammatory pathway. C-reactive protein is an independent marker about this reduction in FEV1 and FVC. Both sexes are involved, independent of smoking. This systemic inflammatory process is not dependent on the smoking at all. The obesity, the presence of other respiratory pathology like asthma, these are important. And what happens in lung response? The altered lung response altered by the complication of diabetes with impaired autonomic nerve function in the lungs of type 1 diabetes patient, that is what happens. Type 2 diabetes affects the specific lung function. It is also affecting different lung function. It has been shown that the alveolar microvascular function is impaired in type 2 diabetes, which we all know even in non-smoker compared to controlled subjects, as demonstrated by the decreased DLCO. And when we are using a specific cohort, that is German COPD and systemic consequences comorbidities network cohort, it showed that hyperlipidemia, which has got a prevalence of almost 43%, is associated with lower intrathoracic gas volume and higher FEV1, when adjusting for risk factor and other comorbidities. So, this is almost sure that diabetes, be it type 1 or type 2, actually hampers different varieties of lung function. I am not going through this slides, but one thing I need to mention, there is a particular gene called this small nucleotide polymorphism gene located in this 15q25.1. Please remember this gene. I will talk to it later. What is the animal model showing about this type 1 and type 2 diabetes? It shows that alloxan induced type 1 diabetes rats, they are more susceptible to emphysema. When we did a bowel fluid in rats, what are the evidences? It shows that reduced number of neutrophils as well as diminished repair of the alveolar walls in response to emphysema. That is happening in in rats who are having diabetes, alloxan induced diabetes, as well as COPD like emphysematous feature. Insulin treatment restored these changes in neutrophil numbers as well as magnitude of emphysematous lesion, and streptozocin induced hyperglycemia in rats results in lung oxidative stress as well as changes in lung structure and gas exchange. So, these are happening in diabetic population in animal models even. This is the mechanistic link between COPD and type 1 diabetes, and if you see systemic inflammation, I do not know whether it is clearly visible or not, very sorry. Systemic inflammation is the main stem. If you pick it up from this area, cigarette smoking, which is ultimately leading to oxidative stress and mitochondrial dysfunction, this related to this systemic inflammation, and this systemic inflammation ultimately leads to either type 1 diabetes or COPD or both. And this systemic inflammation is also the causative agent for insulin resistance. Not going into detail of this lower portion, but that is the crux of what is happening in type 1 diabetes as well as COPD patient. This is about oxidative stress, which is a common feature of COPD and type 1 diabetes, you know better than me, and is caused by an imbalance between oxidant and antioxidant level. The chronic exposure to cigarette smoke and other particulate pollution induces oxidative stress in lungs. It is already, there is no rocket science behind this. Alveolar macrophages from individuals with COPD, they generate increased superoxide radicals. That is what I was talking about, because COPD was once thought to be as a disease of the lungs itself, but right now it has been clearly understood that alveolar macrophages, they are generating different superoxide radicals and hydrogen peroxide compared to those without COPD. What happening to lipid peroxidation and its byproducts? They are also elevated in both lung tissue and exhaled breath condensate in individuals with COPD. So, all this this reactive oxygen species, this superoxide, these are ultimately creating the problem of oxidative stress, and these are linked in patient who are having diabetes. They are prone to becoming COPD, or those having COPD, they are prone to becoming type 1 diabetes. These are metabolic changes in type 1 diabetes and COPD. If you see serum concentration of triglyceride and major choline containing phospholipids, they actually increases. The plasma sphingomyelin has got a negative correlation with COPD, and there are lots of these molecules, this sort of oxidative stress molecules, which increases in both these disease. This is immune response. I am not going into detail of this immune response, but this is important. What happens to, if I take this glucose only, what happens to glucose and COPD? Hyperglycemia can also contribute to airway inflammation, that is important. Glucose metabolism also plays an important role in surfactant mechanism. This dysregulation of glucose observed in type 1 diabetes rat model may potentially lead to dysregulation of pulmonary surfactant synthesis. Finally, the pancreas and kidney transplant, my previous speaker was talking about this, the pancreas and kidney transplant ameliorated the decline in lung function. This is important, and in particular the FEV1 and FVC in a type 1 diabetes population, and this suggests that reversal of type 1 diabetes influences the pulmonary outcome. This is about type 2 diabetes, the mechanism between type 2 diabetes and COPD. Again, the systemic inflammation is important, but you need to consider the lower portion of this chart, because the dysfunctional mitochondria, increased glycolysis, increased fatty acid oxidation, that ultimately leads to this reactive oxygen species, oxidative stress, and reduce effectiveness of this efferocytosis. This is what is actually happening in type 2 diabetes. Not going into detail of this. Inflammatory pathway, you know about inflammation. Chronic inflammation is observed in type 2 diabetes. Individuals with obstructive lung disease have significantly elevated abdominal adipose tissue sometimes, and obesity is a common phenomena in many of our COPD patients. So, obesity, this oxidative stress, that ultimately leading to type 2 diabetes in patients with COPD. What about hyperglycemia and hyperinsulinemia? If you see, higher sucrose intake negatively affect lung mechanics and alveolar septal composition in mice, causing pulmonary extracellular matrix remodeling and reduced elasticity. And high airway glucose may foster a favorable environment for microbial colonization that we all know. In diabetic patient, the infection level is quite high, with glucose in bronchial aspirates increasing the risk of respiratory methicillin resistant staph aureus in intubated patients. About the autonomic dysregulation in diabetic patient, autonomic dysregulation may be attributed to the genetic factors independent of glucose and insulin levels impacting both COPD and type 2 diabetes. The beta 2 adrenergic receptor gene, that is ADRB2, is very important. It encodes a multifunctional protein important for both smooth muscle relaxation in the lung and insulin secretion from the pancreas. Now about the therapy. Sorry for this is from the internet, and sorry for the size of this content, but you just consider the last one, the outcome in patient with COPD and type 2 diabetes, and I am just reading for you. When we are considering metformin, it improves the health symptoms, it improves the health, the quality of life, symptoms, hospitalization and mortality in patients with COPD and type 2 diabetes. It also reduces the likelihood of type 2 diabetes developing into COPD. And type 2 diabetes with moderate to severe COPD with symptomatic improvement measured by the SGRQ and TDI score. The COPD patient with type 2 diabetes are at higher risk of pneumonia, COPD exacerbation and need for mechanical ventilation. Unfortunately, from our guideline, from the COPD guideline, we don't use metformin on a day-to-day basis in all of our patients. But yes, patient with diabetes and COPD, they can be treated with metformin, which will give us this much of benefit. What about inhaled corticosteroid? This is from our domain. Inhaled corticosteroid, if you use inhaled corticosteroid, there is increased risk of new onset type 2 diabetes. Yes, but if you use in a higher dose for more than 3 to 6 months, then only this possibility happens. That is even in a very minuscule situation. There is 34% increase in the rate of diabetes and increased rate of diabetes progression. Also the rate of osteoporosis increase, and no increased risk of diabetes among the current users. And the others drug like thiazolidinediones, like double ATP augmentation, so these are associated with reduced risk of COPD exacerbation and it slows the progression of emphysema. Also, we need to keep in mind about the smoking cessation, because smoking is creating this oxidative stress and the systemic inflammation, which ultimately clump both the disease together. About the diet, you know better than me, so I am not explaining about diet. Exercise is very important. Lifestyle modification is extremely important, because stress is a major factor for the causative agent of both these disease. Thank you. Any question?
Now the floor is open to questions. I have one very simple question, Angshuman. Please let me know the dose of inhaled corticosteroids like budesonide and fluticasone, which can precipitate the development of diabetes crossing that dose.
Right. So, I mean, unfortunately, in my career, I have never seen, I don't know what is Warindam's opinion, I have never seen one patient who is taking inhaled corticosteroid and developing into diabetes. I have never seen one such patient. But the literature says that if the patient is getting a budesonide of 400 milligram, 2 puff twice a day, that is more than 1600 milligram, then there is a probability of increasing chance of osteoporosis as well as increasing chance of new onset diabetes. That is as per the literature. But unfortunately, I have not seen it. The fluticasone dose is more than 2000 microgram, that is 500 milligram, 2 puff twice a day. So if you give it that dose, that is more than 3 to 6 months, then the possibility appears.
Okay, I am glad that Guruda brought this topic up. There are certain studies which put some light on this. Because all the side effects or the bad reputation of steroids, whatever are there, are mostly due to not inhaled steroid, but rather oral or systemic steroids. Okay,
Right.
I would like to highlight that firstly. I will come to this later on. And the inhaled steroid at which dose it is given, it is not associated with metabolic syndrome or diabetes per se, but it is related to some other subtle side effects like more of the osteoporosis and this thing and oral thrush and all these local effects mostly, because there is very little systemic absorption for the inhaled steroids. So, and now coming back to the first point I was talking, if we look at the data that if a COPD patient is not put on inhaled steroids just because of the risk of diabetes, that outweighs the health infrastructure cost and the overall steroid burden on due to repeated exacerbations. Because on every repeated exacerbation, he is just getting a burden of steroids, a sorts of steroid for quite long time. That is systemic, and sometimes that lead to dysglycemia, and that leads to much more. Both the cost of the therapy increases, there is poor lifestyle of the patient, as well as the risk and permanent lung function decline. So I think that's it's more prudent to go for a steroid rather than inhaled steroid rather than oral and wait for the exacerbation. And as far as COPD per se concerned, the guidelines doesn't routinely prescribe steroid for COPD.
Right.
So that is another thing. We need to come out of that habit that to prescribe a formoterol budesonide or something like that to every patient comes with a shortness of breath. So steroids should be reserved till now more for asthma and in only selected acute exacerbation cases or frequent exacerbators of COPD, and not routinely in case of COPD. For routinely COPD, we should much more rely on the LABA or ultra LABA and LAMAs. I hope that's clear.
Arindam, I have an observation because I have done a retrospective study in my clinic. So this is then about 356 patients I have included these type 2 diabetic patients, COPD patients, and among these 37% have diabetics. And the thing is that this my observation, as the COPD increases, stage of severity of COPD increases, diabetes HbA1c is on increases. Is it true in your clinic also?
That is actually proven in some studies, because as I told you, patient having COPD turning into diabetes, there are studies, but the vice versa studies are not there.
It's not there.
Now, patient with gold stage 1 COPD or gold stage 2 COPD, the conversion to diabetes or happening new onset of diabetes, I think if I am not mistaken, the percentage is around 12.7 or 13%.
Yes.
But
Yes.
if it is gold 3 or 4, probably because of more exacerbation, probably because of more use of oral steroid or whatever it is, or because of the stress factor, the number increases even up to 34 to 40%.
Yes.
So that is what literature says about gold stage 3 and 4, and that is what we see also.
Arindam has told the right thing, because it is the habit of using this oral steroid in every COPD patient, but it is not the true. If you have to give this LABA-LAMA combination more for the treating a COPD patient, but it is a common habit. You are always using this LABA and the ICS.
Now,
So that
two
may be
things.
so.
Two things I need to. I think I should add. Number one is we have multiple good inhalers right now with us.
yes.
Multiple long-acting inhalers. We don't need to believe or rather rely on steroid only for COPD patients.
Yes, yes.
As Arindam told, only in case of exacerbation or patient who are having more eosinophils, they can be chosen for steroid.
Yes.
But if we judiciously use this newer inhalers, we can avoid steroid, number one. We can avoid exacerbation. We can have a better quality of life for COPD patient with less stress, which will ultimately lead to less incidence of diabetes in those patients. So that is what I suggest in all patients of COPD.
At least what has been that is the vice versa. If the patient is diabetic, that no drug that will definitely go on to increase in the COPD. So, but this vice is true. But it's a COPD drug, and if you treat the patient with the the steroid, it can put the patient into a risk of diabetes. So that is my take.
So if there is not any more question, may I ask Guruda to conclude the session?
To conclude this,
Arindam, I just want to ask one thing. Actually, I am a nephrologist, but diabetic kidney disease patients who are not on dialysis and having COPD, what is the exact duration of oral steroids which are to be given to them once they have respiratory distress, even after all the inhalers that have been prescribed by the pulmonologist? That's what we want to know.
So that's a very good question actually, because I have seen lots of prescription where people are giving oral steroid like in a fanatic manner. Some are giving like 10 days, some are giving like 14 days, some are continuing with a tapering dose. What I feel what I did in my clinical practice is, I don't give steroid more than 10 to 15 days, and that too, if possible, restrict it within 5 days, because oral steroid for 5 days is good enough in patient of COPD to control this exacerbation. If it is not happening, you have to admit that patient. You might have to
Yeah,
consider
that's what happens actually.
Exactly.
Once they have been given at least say 30 for 5 days with a rapid tapering over 2 to 3 weeks, the patient lands up with volume overload, a rise in creatinine or a sepsis. Means we have had several such admissions.
And the problem is there is multiple, different dosing of steroid. You will see that
Exactly.
someone is giving methylprednisolone 16 milligram twice a day. I don't know where from this twice a day dosing is coming of the steroid. So twice a day methylprednisolone, some are giving it for the first day, they are giving, and when you are giving steroid with a say 0.5 milligram per kg per day or maybe 1 milligram per kg per day, you are giving a steroid in a 60 kg body weight, you are giving a steroid of 30 milligram, Visolon, say 30 milligram we are giving. People are like, oh, you are giving 30 milligram, it should be reduced to 5 milligram or 10 milligram. What is going to happen in that patient? Neither the exacerbation will come down, and you are having lots of side effect because of the steroid. So judicious use of steroid is actually very good, but problem with our country is nobody is using it in a judicious manner. I don't know why.
I would be happy to prescribe a patient on a 30, even 48 milligram of steroid for 3 to 5 days rather than 5 milligram of steroid for his entire life or 3 months.
True.
That's an entire topic of discussion. We should conclude now. So in the concluding remark, I will tell that we should not be afraid of prescribing statins to augment the onset of diabetes. In the same way, we should not be afraid of prescribing inhaled corticosteroids to asthma, maybe in some COPD patients, in fear of they developing diabetes. That is the bottom line of this discussion, and the discussion has been very
And also
interactive
vaccination.
also.
Also vaccination in every diabetic patient.
Absolutely.
Let us conclude the session. Thank you.
Thank you, sir. Thank you, speaker. Thank you, chairperson. Now, I would like to request our chairperson to please felicitate our speaker. Now, I would like to request Dr. Mridul Bera to please felicitate our chairperson. Now, it's time to felicitate our chairperson.